Well, welcome back. This session and the next are going to be devoted to obstructive diseases of the lung. These are major causes of morbidity and mortality, and so are extremely important. In this session, we're going to look at chronic obstructive lung disease, and in the next, we'll go to asthma and localized airway obstruction. Now, chronic obstructive pulmonary disease, or COPD as we'll call it, is extremely common. In fact, it's the third most important cause of death after cancer and heart disease. And one of the tragic features of this disease is that much of it is preventable. It's essentially caused by smoking, and it's a terrible indictment that this scourge remains as it does. Now, all these diseases are going to be linked with obstruction to the airways, and so let's look at three mechanisms of airway obstruction. On the left, we can see an airway which is partly occluded by material within it. That could be retained secretions, as in chronic bronchitis, mucus plugs, as in asthma, edema fluid, as in pulmonary edema, aspiration of material postoperatively, or maybe an inhaled foreign body, for example, a peanut in a toddler. All these obviously could cause airway obstruction. The next, in the center here, is obstruction caused by an increase in thickness of the airway wall. This can be caused by inflammation, for example, in chronic bronchitis or asthma. Also, there can be hypertrophy of bronchial smooth muscle in asthma, or hypertrophy of bronchial mucus glands in chronic bronchitis. All these can increase the thickness of the airway wall. And then finally in C here, we see a slightly different situation. And this reminds us that the caliber of an airway depends on two factors. One is its intrinsic mechanisms that can make it smaller. For example, the smooth muscle in the wall with tone and the elastic tissue. And the other is the radial traction of the alveolar walls around it. These tend to pull it open. So that if the alveolar walls are destroyed, as they are in emphysema, then this radial traction is lost and the airway becomes smaller. Now let's turn to COPD, and this image makes the point that most patients with COPD are a mixture of emphysema and chronic bronchitis. And often it's not at all clear as to how much of each a given patient has. There are situations, for example, a relatively young man, a 40-year-old, who has alpha-1 antitrypsin deficiency, is a non-smoker, has no cough. That person is likely to have a relatively pure emphysema. But most patients with COPD have a mixture. And therefore we use, and these patients often have shortness of breath over a series of years, chronic cough, reduced exercise tolerance, airway obstruction, overinflated lungs, and impaired gas exchange. And we use the term COPD as a convenient, nondescript label that avoids making an unwarranted diagnosis with inadequate data. Now, occasionally it's useful to have a formal definition of a disease, and this is the definition that's often accepted for emphysema. It's a disease that's characterized by enlargement of the air spaces distal to the terminal bronchiole with destruction of their walls. Now that leads us to remind ourselves of the terminal bronchiole, and here's a diagram of the airway system, the Weibull model that we've referred to several times previously. And you'll recall that the terminal bronchiole is the smallest of the conducting airways, shown here. And this subtends or supplies the acinus, or the unit of gas exchange. And so the disease in emphysema is distal to the terminal bronchiole. Therefore, it's in the parenchyma of the lung rather than in the larger airways. Now it turns out the histology of emphysema is very instructive, and this is shown here. At the top we've got the histology of the normal lung, a thin lung section, and you can see the alveolar ducts and the alveoli very clearly. And now we go to the lower image and you can see this terrible destruction that occurs in emphysema, with breakdown of the alveolar walls. Large amounts of the capillary bed, of course, are destroyed because the capillaries run in the alveolar walls. And you can also see that these small blood vessels here, one here and one here, lack the normal radial traction of the parenchyma around them. And that would be also true of the airways. So that's a striking example of emphysema. And here's another one which is made in a slightly different way. The lung has been fixed and has been sliced and has been looked at with a hand lens. And in this upper image here, you can see the alveolar ducts and alveoli. The alveoli are about 1/3 of a micron in diameter. We can just pick them out at this magnification. And down here we have typical appearance of emphysema, breakdown of the alveolar walls, complete disorganization of the lung structure, and therefore you can see how a large number of pathophysiological processes would follow. And I think it's very useful to keep these appearances at the back of our mind when we think about lung function in emphysema. Now it turns out that the distribution of emphysema in the acinus varies. On the left we see the normal drawing with terminal bronchiole here, the respiratory bronchioles and the alveoli. And in centriacinar emphysema here, the disease is limited to the center of the acinus, as you can see, and the alveoli in the periphery are spared. Contrast that with panacinar emphysema, where the disease occurs throughout the whole of the acinus. So these are very different patterns. Now, what could be responsible for the pattern in centriacinar emphysema? Well, we've talked before about the fact that when pollutants are inhaled as aerosols, they reach the terminal bronchioles by convective flow, like beer being poured out of a pitcher, but they don't get to the peripheral alveoli easily. In fact, they don't get there at all, because they don't diffuse rapidly enough in the gas phase. In the acinus, the primary mode of transport is diffusion in the gas phase. And the pollutants tend to therefore settle out in the center of the acinus. And that would be quite a reasonable explanation of why this disease occurs in this way. Let me remind you, we've seen this slide before, of the location of dust in a coal miner's lung. And this makes the same point, that the dust tends to occur in the center of the acinus. The acinus, the edge of it is around here somewhere. And you can see it's located in the terminal respiratory bronchioles here, and the alveoli are completely spared. And the same thing is shown in this drawing at the top here. So this is a dramatic demonstration of the fact that the center of the acinus is very much at risk. Now, what about the situation in panacinar emphysema? Why do we see a different pattern there? Well, I presume that the mechanism of disease, the pathogenetic process, is different in panacinar emphysema. And it may be that it has to do with an imbalance of the protease anti-protease system that we're going to be talking about in more detail in a few minutes. So let's leave it until then. And that this disease depends on the distribution of blood flow, not the deposition of pollutants as in centriacinar emphysema. Now it turns out that centriacinar emphysema has an interesting topographical distribution in the lung, and you can see this very clearly here. Severe emphysema at the apex of the lung, less as we go down, and the base of the lung is essentially spared. Now, what's the reason for that? Well, I think an explanation is as shown here, and we've talked about this previously in the respiratory physiology sequence. This side, we can see that because of gravitational factors, the blood flow is different, being lower at the top of the lung than the bottom, and the ventilation is also different, but rather a smaller difference, and therefore the ventilation perfusion ratio is high, and there are differences in the PO2 and PCO2. On this side, we can see what happens because the lung is distorted by its own weight. And as a result, the alveoli are large at the top of the lung, the transpulmonary pressures are greater, that is to say the difference between alveolar and intrapleural pressure is greater, and the stresses are higher, the mechanical stresses in the lung are greater. And you may have airway closure at the bottom of the lung because of this distortion. Now it makes sense that if you've got some disease throughout the lung, deposition of pollutants throughout the lung, as we see here, as you could imagine here, then the lung will fail first where it's stressed most. The stresses are highest at the apex, and that I think is a reasonable explanation for the distribution of centri-acinar emphysema. Now, there are other types of emphysema as well, and this shows an example of what's called paraseptal emphysema. In this case, the damage is seen adjacent to fibrous septa in the lung that separate the lobules. And the engineers have a term for this kind of thing. It's called stress concentration. And what this means is that if you've got an expandable material like the lung adjacent to something that does not expand, then you get a concentration of stresses here. And that's probably a reasonable explanation for the location of paraseptal emphysema. You can also get what's called bullous emphysema, as shown here. Large balloon-like structures occur, often at the top of the lung, though not always, and probably the high stresses in this region are in part responsible for this. Now there's another type of distribution that's shown here, and that is emphysema which tends to occur principally in the lower regions of the lung. And that's often seen in this disease, alpha-1 antitrypsin deficiency. Now this is an uncommon disease, but of particular interest because of the light that it possibly throws on the mechanisms of other types of emphysema. In alpha-1 antitrypsin deficiency, which is a heritable disease, patients who are homozygous for the ZZ gene develop this disease at a relatively early age. By that I mean perhaps in their 40s. They may be non-smokers and have no bronchitis at all, and yet they develop this disease. And it tends to occur at the bottom of the lung, presumably because that's where the blood flow is highest, and that's where the trypsins are located because of the high blood flow, and the absence of antitrypsin causes destruction to occur. And this interesting disease, first of all, it can be shown by an electrophoretic pattern here, where you can see the absence of the alpha-1 antitrypsin marking here. And this disease suggests a possible pathogenesis of emphysema generally. In these patients, almost certainly, the disease is caused by an imbalance between the protease, the trypsin, and the antiprotease, the antitrypsin. And it's tempting to think that this may be true of other types of emphysema as well. We know, for example, that cigarette smoking results in the release of neutrophil elastase. Neutrophils contain large amounts of elastase because they use the enzyme to break down bacteria and so on that they engulf. And elastase is perhaps a misleading term because not only does it attack elastin, but it also cleaves collagen as well. So it's actually a collagenase as well as an elastase. And it seems likely that cigarette smoking, because it releases neutrophil elastase, may cause an imbalance between the protease and antiproteases in the lung. We know that neutrophils are marginated in capillaries in the lung. That happens under normal conditions, and there's some, in other words, they tend to be held up in the capillaries of the lung. And there's some evidence that smokers have increased margination of their leukocytes, including their neutrophils. So this may be part of the mechanism of this. Now, of course, if you've got breakdown of the collagen in the lung, then clearly the lung is very vulnerable. And one of the questions may be, what is the most vulnerable region of the lung? And I think that the blood-gas barrier is a good candidate for that. Here we have an electron micrograph of a pulmonary capillary that we've seen now a number of times before, just to remind you of the extremely thin blood-gas barrier on one side. And here's an electron micrograph showing a very high power view of just a portion of the barrier. This little portion here has been blown up. And what's interesting about the blood-gas barrier is that in the extracellular matrix, between the epithelium and the endothelium, you have an extremely thin layer of type 4 collagen, indicated by the arrow here. Actually, you can see this electron-dense layer in the center of the extracellular matrix. We believe that's responsible for the strength of the barrier, and so this looks like an extremely vulnerable region which may be destroyed if there is a protease that is unaffected by the antiprotease. There's an imbalance between the two. That's a hypothesis, but I think it's an interesting one. Now let's move from emphysema to chronic bronchitis, the second of the two diseases. And let's have a definition. And the definition is that it's a disease characterized by excessive mucus production in the bronchial tree, sufficient to cause excessive expectoration of sputum. And I should say, with modern antibiotic therapy, we don't see so much expectoration as we did in the good old days, but it still occurs. You'll notice that this is a clinical definition, as opposed to the definition of emphysema, which was anatomical, a breakdown of the alveolar walls, increase in air spaces distal to the terminal bronchiole. And you may say, well, how do we know if a person's got emphysema if we need to see an anatomical evidence of it? Well, of course, we don't normally have that, but now with modern imaging techniques, we can get a very good idea if emphysema is present. But chronic bronchitis is a clinical definition, and it has to do with the mucus glands in the bronchial wall. And this is a drawing to remind us of the mucus glands which are situated between the epithelium of this airway here and the cartilage here. And you can see the mucus glands clearly, and you can also see some arrows here, and this is just to indicate that you can actually measure the amount of the mucus glands by this distance here divided by the total distance here, BC divided by AD. So this is the normal appearance of mucus glands in the airway wall. And just to remind you of the function of mucus, of course, the mucus is deposited onto the airway wall and swept along by the mucociliary escalator, and that's the way in which dust particles are removed from the lung. So the mucociliary escalator is a critical factor in maintaining the cleanliness of the large airways. And the mucus, by the way, not only comes from the mucus glands that I showed you in the previous slide here, with their duct leading the mucus to the surface, but also goblet cells that are located in the bronchial wall epithelium here. Now, we saw the normal appearance of mucus, and look at this remarkable these remarkable micrographs here. First of all, here's the normal situation. Here's the airway epithelium. The lumen of the airway is here. Here's the cartilage, and here's the layer of mucus glands, or sometimes called seromucus glands. Okay, quite clearly seen. Now go down to this remarkable picture in chronic bronchitis. You can see the whole of this region of the airway is occupied by hypertrophied mucus glands. Here's the epithelium here. Here is the cartilage here, and this enormous hypertrophy of the mucous glands. So that's characteristic of chronic bronchitis. So what happens is these hypertrophied mucous glands secrete very large amounts of mucus in response to the inhaled pollutant, generally cigarette smoke, and these very large amounts of mucus on the airway walls completely overwhelm the mucociliary escalator. You may remember that we talked about the critical importance of maintaining the thicknesses of the two layers of the mucus, the sol layer and the gel layer of the mucus. And obviously, if you're going to produce vast amounts of mucus with these abnormally hypertrophied mucus glands, you're going to interfere with the function of the mucociliary escalator, and that's what happens in chronic bronchitis. Now, we've been looking at the large airways, but it's very important to realize that in chronic bronchitis there are important changes in the small airways. In fact, that is probably where the first changes occur, as we were talking about when we mentioned the deposition of pollutants. The pollutants tend to deposit in the small airways. And histological pictures show that in the small airways of people with chronic bronchitis, you've got inflammation of the airways, edema of their walls, that's part of the inflammation, narrowing of the airways, you've got cellular infiltration, and you can also get some peribronchial fibrosis. So the changes in the small airways are critically important, and we'll say a little bit more about those later on. Now, what causes these changes in chronic bronchitis? Well, of course, it's the inhaled pollutants, and I just want to show you the dramatic effects of the inhalation of a single cigarette, smoke from a single cigarette, on airway conductance. Airway conductance is the reciprocal of resistance. So this means that the conductance of the airway here, here's a cigarette, is smoke here, and then look at the terrific reduction in airway conductance, and this lasts for an hour or so, just a single cigarette. So this stuff is really toxic, and we should do everything we can to get rid of this terrible scourge of smoking. Now let's talk a little bit about the clinical presentations in COPD. And the vast majority of patients have a sort of mixed presentation, but it's very interesting that there are extremes called the type A and type B that are interesting to look at. And the type A patient, shown here on the left, is typically a rather thin person, sitting up in bed, as you can see, and desperately short of breath. He's very dyspneic because his ventilation is high, and his high ventilation allows him to maintain an almost normal arterial PO2. It's never completely normal, of course, but it's not grossly reduced. And his PCO2 will be normal. But he will be desperately short of breath, and it's a pitiful sight to see a patient with a pure type A who is very short of breath. He has large lungs, as we'll see in a moment, and this is a good opportunity to look at the radiographs of a patient with emphysema. Here's a normal radiograph on the left here, and on the right you can see a typical radiograph in severe emphysema. You can see that the chest is overinflated, the ribs are more horizontal on this side than over here. You can see that the diaphragms are low, the mediastinum is narrow, and the lung fields are over-penetrated. Now, you need to see good films and they don't reproduce very well, but the lung fields are over-penetrated here. And if you have films that can show the small blood vessels, as you can in a digital radiograph, you can see the small blood vessels here. This is a normal digital chest radiograph. You can see the small vessels, and in a patient with emphysema, these vessels disappear because of the destruction of the alveolar walls. We can also see, with digital techniques, the changes in emphysema. And this is a CT scan, and if you look carefully here, you can see the small holes caused by the emphysematous process here. Okay? and that's the destruction of the alveolar wall. And incidentally, on this beautiful CT, you can also see paraseptal emphysema here. I can see it anyway, and here. And this is, so these are changes in emphysema. So the point I was making is that while in principle, we need a histologic picture of emphysema because it's an anatomical definition. In fact, with modern, highly sophisticated imaging techniques like this, we can see the changes in emphysema without a problem. So that was the type A presentation. Now let's look at the type B presentation, who's a very different kind of person. This man probably has a very long history of cigarette smoking, and he has severe chronic bronchitis. He's coughing up phlegm all the time. In fact, the artist has put a couple of sputum pots here to collect that. He tends to be lying back in bed. He's not nearly as short of breath as this man here, but he's blue, he's cyanotic, his blood gases are very abnormal. He has a much lower PO2 than this man, and he probably has an increased PCO2, sometimes called respiratory failure. He also has evidence of right heart failure. He has an increased pulmonary artery pressure, pulmonary hypertension, got evidence of heart failure with the triad of engorged neck veins, palpable liver, and peripheral edema. And this is the type B type of presentation. And as I said earlier on, most patients, of course, are a mixture of the two, but it's interesting to look at these two extremes here. So the type A patient is the fighter. He is unwilling to see his PCO2 rise, and we talked about this before. If the PCO2 rises, it alters the pH of the blood, changes the function of enzymes, configuration of proteins, has effects on the central nervous system. So often patients fight hard to maintain their PCO2 normal. As a result, he's called a fighter and sometimes called a pink puffer. Medical students can always remember that. A pink puffer, pink because he's not cyanized, and puffing because he's breathing so hard. By contrast, the type B patients can be called quitters. They are people who have elected not to try and keep their PCO2 at the normal level because the dyspnea associated with that is so unpleasant. And if you like, they've traded an increased PCO2 for a better life in not breathing so hard. And they're called the blue bloaters. They're blue because they're cyanosed and they're bloated and they have some water retention as well. And those are the classical definitions, descriptions of the type A and type B patients. Now let's move to pulmonary function in COPD. And the first thing to say here is keep at the back of your mind the histological appearances that I showed before, because often we can predict the kinds of changes. And the ventilatory capacity and mechanics, of course, are grossly affected. And the main problem with COPD is airway obstruction. And we're all familiar now with the forced expiration, the normal pattern shown here, and the obstructive pattern where the FEV1 is grossly reduced because of the very severe airway obstruction. The FVC is also lower, and this is because the diseased airways close prematurely towards the end of the expiration. The cause of the obstruction is dynamic compression of the airways. We talked about that in the previous session where we talked about pulmonary function tests, and I talked about it extensively in the respiratory physiology series. I'm not going to go into the mechanism of it now, but it's of course extremely important. And the carry-home message is that during dynamic compression of the airways, airflow is independent of effort. There's no way the patient can increase his effort. Another way that we frequently look at the obstruction is by plotting flow volume curves shown here, and the typical obstructive pattern shows a scooped out appearance, and these very low flow rates at low lung volumes. See, we're exhaling here from TLC down to residual volume, and at these very low lung volumes, flow rate is principally determined by the very small airways, and in chronic bronchitis, these, as we've seen, are diseased. Let's look at lung volumes in COPD. They are typically all increased. The total lung capacity, functional residual capacity, and residual volume are all typically greatly increased. And in addition, when we make the measurements of lung volumes, and if we do this using both the helium dilution and the body box or the plethysmograph, we see a difference between the two measurements, because the helium dilution technique only measures the volume of the lung which is connected to the mouth. But there may be obstructed airways here, or there may be airways where the rate of mixing of the helium is terribly slow because of uneven ventilation. And whereas the body box measures the total volume of gas in the lung, the helium dilution will give you a smaller number, because not all the sections of the lung are communicating with the mouth. The reason for the high lung volumes is the abnormal pressure volume curves in emphysema. And here we can see the volume here plotted against the transpulmonary pressure here. And in emphysema, you've got an increased volume for the same pressure and a steeper slope here. Compare that with the normal, which is the red line here, and interstitial fibrosis gives you a very stiff lung, as you can see. Why the emphysematous lung has a high compliance, I like to think of it really that what we've done is we have destroyed the architecture of the lung, and therefore we've destroyed the ability of the lung to have its normal recoil. I think that's probably the simplest way of thinking about it, and of course it's not surprising when we see a picture like this where the architecture is destroyed. Gas exchange in COPD is grossly impaired, of course. Obviously, with the destruction of the architecture I've just shown, there has to be extensive ventilation perfusion inequality. There's no way that lung can be ventilated and perfused in the normal way. And so all these patients have hypoxemia, and some of them have CO2 retention. Now, I'm not going to go into this whole question of CO2, PCO2 in COPD. We've talked about it previously. Just to remind you that ventilation perfusion inequality interferes with the transfer of carbon dioxide by the lung. VAQ inequality makes the lung inefficient at gas exchange for all gases, including CO2. And the only reason why we see many patients with COPD, for example, our type A patient that we saw a couple of slides back, the only reason why we see these patients with a normal PCO2 is that they've been able to bring the CO2 down, as it were, below what it would be if they didn't hyperventilate, by increasing the ventilation to their alveoli. So patients with ventilation perfusion inequality would have CO2 retention if they did not increase the ventilation to their alveoli. And the type B patient, as we said before, often will allow his PCO2 to rise because he cannot cope with the severe dyspnea. He's willing to trade an increase in PCO2 for a slightly lower ventilation, which will make him very much more comfortable. The ventilation perfusion inequality, of course, increases the alveolar arterial PO2 difference, and if you calculate the physiologic dead space and the physiologic shunt, these are also increased. It's possible to look at the pattern of ventilation perfusion inequality in patients with COPD. We don't do it in the pulmonary function laboratory setting, but in a research setting it can be done. And this is the normal distribution of ventilation perfusion ratios that we've seen previously. Ventilation and blood flow on this axis against ventilation perfusion ratio here. And as you might expect in the normal lung, all the ventilation and blood flow are situated close to the normal ventilation perfusion ratio of about 1. But now look what happens in a typical type A patient. What you see is a normal mode here, if you like, not far from one, but an abnormal mode with a large amount of ventilation going to lung units with very high ventilation perfusion ratios. Presumably, those are regions of the lung where the capillaries have been destroyed by the emphysematous process, but ventilation is still taking place. And this reflects a very high physiologic dead space, and this type A patient is not likely to have much hypoxemia because there's not much blood flow going to very low ventilation perfusion ratio units. But now if we look at the type B patient, we see a completely different situation. Again, the reasonably normal mode here, but now a mode showing a large amount of blood flow going to lung units with very low ventilation perfusion ratios. And presumably these are the units behind grossly diseased airways, which cause obstruction to ventilation. The ventilation is greatly reduced. The blood flow is still occurring through these regions, and this is responsible for the cyanosis, the very low arterial PO2 in the type B patient. Incidentally, notice that in spite of this very severe disease, there's no shunt, no blood flow to unventilated alveoli. That was a big surprise to us when we first found that. It's not always the case that there's no shunt, but there always is relatively little shunt in these patients. And I think it probably has to do with collateral ventilation, which is allowing some ventilation to these alveoli, but not through the usual channels. Let's look briefly at the pulmonary circulation in COPD. It's abnormal. These patients, particularly the type B patients, develop pulmonary hypertension. And that has several causes. One, of course, is just the destruction of the capillary bed. Many of the capillaries, which are in the walls of the alveoli, are destroyed. In addition, there's hypoxic pulmonary vasoconstriction because of the low alveolar PO2 in low VAQ areas. And just to remind you, hypoxic pulmonary vasoconstriction means that in a poorly ventilated region, because of an obstruction here, the blood flow to that region is reduced. In addition, these patients often have some polycythemia. It's a minor effect, I think, increasing blood viscosity. And also there are pathological changes in the walls of the small arteries. Patients with pulmonary hypertension often develop right heart failure with fluid retention, dependent edema, and the right heart enlargement can be seen both in the ECG and with more difficulty in the chest X-ray. So these patients develop pulmonary hypertension, and a patient with, particularly with the type B type of presentation, who develops pulmonary hypertension with CO2 retention, the prognosis in that case is relatively poor. These patients have a very high work of breathing. Now, of course, that's not surprising. They've got severe obstruction to the airways, and so it takes a lot of oxygen to the respiratory muscles for these patients to ventilate. And one way of demonstrating that is shown here. We can ask normal subjects to voluntarily hyperventilate. And if we do that, they increase their ventilation to, say, 80 liters a minute. There's almost no increase in the total oxygen uptake of a normal subject if he increases his ventilation to 80 liters a minute, say. But look at the patient with COPD. The moment he is asked to hyperventilate, which he finds very difficult to do, of course, because of the dynamic compression of his airways, but he tries to hyperventilate, and enormous oxygen uptake, and that simply just reflects the tremendous work of breathing in these patients. Now, there's a lot of interest in trying to detect changes in early disease, because unfortunately, particularly in emphysema, once we get breakdown of the alveolar walls, there's nothing you can do about that. And in general, patients with COPD do not respond to therapy particularly well. And so the hope is to catch these patients in an early stage. Now, what we'd like to do with chronic bronchitis is to pick up the increased resistance of the small airways at an early stage. Difficult to do because, as we've said several times now, the small airways constitute a silent zone. The amount of airway resistance in the small airways in the normal lung is very small. So it's difficult to pick up an increase in resistance of the small airways. And possible ways of doing that include the closing volume, which we've talked about before, and the flow volume curve. And this is just to remind you again of the flow volume curve and the fact that when we get down to these lower regions of the flow volume curve here, the flow rate is increasingly dependent on the very small airways. So that gives us some indication. What about the management, the treatment in COPD? Well, unfortunately, the destruction of lung tissue is irreversible. Apart from transplanting a lung, there's nothing much you can do about the destruction of the lung tissue in emphysema. For bronchitis, of course, you use antibiotics as much as you can, both to treat the bronchitis and particularly to prevent exacerbations. And some patients with chronic bronchitis have reversible bronchoconstriction. And of course, their bronchodilators will be used. In fact, some physicians now routinely use bronchodilators in all cases of chronic bronchitis, in all cases of COPD, because there may be some reversible bronchoconstriction, and you're not going to do any harm by giving bronchodilators. The pulmonary hypertension can be treated to some extent by continuous oxygen therapy, and that's used via nasal cannulas for patients who have a very low arterial PO2 and are developing pulmonary hypertension, because the prognosis of these patients is linked to, in many of these patients, is linked to pulmonary hypertension. Other patients can have portable oxygen that can improve their mobility, and often you've seen patients, now you can use liquid oxygen containers, nasal cannulas, and patient can go shopping, go to the movies and so on. Lung volume reduction surgery is available for some patients, and that can improve the quality of life over a period. And also rehabilitation programs are important. Rehabilitation programs probably don't greatly change pulmonary function or even exercise capacity, although they may to some extent. But the attitude of the patient to his or her disease is very, very important, and rehabilitation programs can be critically important there. Well, that's all I'm going to say about COPD, a desperately important subject. Let me just finish though by saying that I think we all have an obligation to try and prevent smoking, try and get rid of this awful scourge of cigarette smoking. We're making good progress, I should say, particularly here in California, but it's desperately important that we get rid of smoking because it's responsible for a very large amount of this terrible disease, COPD. And I'll leave it there and look forward to seeing you next time. Well, welcome back. In this second session devoted to obstructive diseases of the lung, we're going to be looking at asthma. In the first, you'll recall, we looked at COPD in some detail, and of course these diseases are very different, these two diseases. For example, obstructive COPD is largely preventable if we can get rid of this scourge of smoking. It mainly occurs in middle-aged to older people, whereas asthma occurs at all ages, but particularly in young people. And interestingly, the amount of asthma appears to be increasing, particularly in well-developed countries, and we don't know why this is. So let's start with a definition of asthma here. It's a disease characterized by increased responsiveness of the airways to various stimuli, manifested by inflammation and widespread narrowing of the airways that changes in severity either spontaneously or as a result of treatment. Incidentally, it's interesting that for a very long time people have recognized the increased responsiveness of the airways, but the role of inflammation is a more recent development, and we'll say more about that. Let's look at some of the clinical features of asthma. Now, it often begins in children, but it can occur at any age. Sometimes, but not always, there's a specific allergen that can be found. For example, ragweed, or an animal such as a cat, or pollens, particularly serious in the spring, for example. And there may be other features of atopy, for example, allergic rhinitis, eczema, something like that. So there is an allergic form of asthma, but there is also a non-allergic form, and the reasons for that are not so clear. As we've seen, there's a general hyperreactivity of the airways, so that they respond to factors other than allergens, such as smoke. In fact, secondhand smoke is a serious problem with some people, cigarette smoke. Cold air is another factor, exercise also, aspirin. All these things can cause hyperreactivity of the airways. This can be tested using methacholine, which induces spasm, induces bronchoconstriction, and is a useful way of, is useful in the diagnosis of the condition. During an attack, the patient is usually anxious, has a lot of anxiety, and in fact psychological factors are important in asthma. Sometimes people who get into a situation where they are challenged psychologically will develop an asthma attack. There's a condition known as status asthmaticus, which can continue for many hours. Now, a normal attack of asthma is relatively short-lived, a few minutes to an hour or so. But in status asthmaticus, the condition may continue for 24 hours, a couple of days. The patient becomes exhausted. The airways are unresponsive to treatment. It's a serious condition and requires aggressive therapy. Now let's look at some of the pathological changes in the airways, because that's where most of the action is. And first of all, on the left here, we've got a drawing of a normal airway with a nice large lumen, as you can see. Here's the airway epithelium. We've got a relatively small amount of airway smooth muscle around it. The airway wall itself is not very thick. We have mucus glands in the airway, and we have some cartilage as well. And look at the changes that we see with asthma. Well, the first thing we note is that the caliber of the airway is greatly decreased. And I suppose in this particular instance with the mucus here, we may have it reduced, well certainly it's reduced to more than 1/2 of its normal diameter. Now you'll recall when we discussed airway resistance in the session on pulmonary mechanics that we referred to Poiseuille's law, and that refers to laminar flow in airways. And Poiseuille's law says that if you reduce the caliber of an airway to 1/2, you increase its resistance some 16 times. There's a radius to the 4th power. So you can see that in an instance like this, where we have a nice large airway like this, which is reduced in its caliber to certainly more than 1/2 here, there's a tremendous increase in airway resistance. Now in this airway you can see a small amount of mucus, and there is mucus produced in asthma, nothing like as much as in chronic bronchitis, but the mucus tends to be viscid, sticky, difficult to move, and it can completely plug the airways, as we shall see. We then get to the cells lining the epithelium here, cells lining the airway, and then we get a big increase in the thickness of the airway itself. See, it's greatly increased in thickness, and that has to do in part to the inflammatory changes and the edema of the airway walls. There's also an increase in the thickness of the smooth muscle. You get hypertrophied bronchial smooth muscle here, which contracts. You can also see the increase in the mucous glands in the airways, a little bit like the situation in bronchitis, where you recall that one of the most important pathological features is the hypertrophy of the bronchial mucous glands. And then we can see, of course, the cartilage here, which is unchanged. So dramatic changes in the appearance of the airways in asthma, leading to a striking reduction in the caliber of the lumen, and that of course is responsible for the big increase in airway resistance. Now, as I said, sometimes the airways can be completely obstructed by mucus, and here's a very nice light micrograph showing this with an airway probably cut transversely here, which makes it this rather strange shape, and you can see the mucus within it. You can also see, incidentally, some remodeling of the basement membranes here. This is called reticular basement membrane, and it's a form of remodeling that occurs in asthma. You can also imagine that this smooth muscle here is hypertrophied and contracting, and that's giving us this contracted airway completely obstructed by mucus. Patients who die in status asthmaticus at autopsy show many of their airways completely obstructed by mucus. As I said, the mucus in asthma is difficult to move and difficult to cough up. Now let's talk about the pathogenesis of asthma. And we've already referred to the airway hyperresponsiveness, not only in response to the allergen, but response to cold, exercise, smoke, whatever. In addition, we've mentioned the airway inflammation, which, as I said, has only been emphasized in the last 15 or 20 years, but it's a very important feature of asthma. Often, as we said, there's an allergic basis, but not always. There is both allergic asthma and non-allergic asthma. Now, what's responsible for the increase in the amount of asthma we're seeing? And that's particularly the case in well-developed countries. Well, I don't think anybody knows, but an interesting hypothesis is the hygiene hypothesis. And this has to do with the fact that young people today are not exposed to the potential allergens that many of us were exposed to when we grew up. And if I can just give you an example with myself, my mother's people came from a farm, and I used to go down to the farm quite frequently in the holidays and so on. And there I was closely surrounded by sheep and horses and cows, and they were defecating everywhere. So I was certainly exposed to all sorts of factors on a farm. If you go and visit my grandchildren who live in a very nice house, you've got to take your shoes off before you get into the house. So it's a very different environment, and one of the hypotheses is that the immunological system developed at an early stage in response to these factors, dirt and fecal factors and so on, and today this doesn't happen. Whether that's true or not, I don't know, but it certainly fits with the fact that in well-developed countries, the asthma is increasing tremendously. But there are also pollutants that are blamed, and some people think that engine exhaust, for example, particularly perhaps diesel engine exhaust, is a factor. There's also a genetic component to asthma, although it's not a simple series of events. It's a complicated genetic thing, but some people think that may well be a factor. Now let's look at a scheme for the pathogenesis of asthma. In this particular scheme, there's an antigen here, some kind, and the combination with lymph cells, and mast cells are stimulated. Now, it used to be thought that mast cells were particularly important in the generation of the asthma attack, but now a lot of people think that other cells are important. For example, eosinophils may be very important, and other cells as well, leukocytes as well, so that people don't concentrate quite so much on the mast cell now as they did. Whatever cell it is, it releases mediators, or is responsible for the development of mediators, and these can be of a big variety here. And these mediators have two separate effects. One is that they induce inflammation, and in fact, for example, in the capillary, they will increase permeability, they will cause edema of the wall of the airway, for example, and other inflammatory changes as well. And in addition, they will affect the airway smooth muscle by reducing the concentration of adenyl cyclase, reducing the concentration of cyclic AMP, and that leads to contraction of airway smooth muscle. So let's go on and look at the possible inflammatory mediators. Now, there's a whole variety of these, and I should emphasize that research on the mechanism of asthma is a very active area, and things are changing all the time. But here are some of the inflammatory mediators that have been recognized. For example, there are cytokines associated with T helper cells. These include a variety of interleukins, as you can see here. There are the arachidonic acid metabolites, including leukotrienes and prostaglandins. Histamine has always been thought to be an important factor in asthma, and that's one reason why the mast cell was implicated so much early on, and also platelet activating factor. So there's a great variety of inflammatory mediators, and these are being studied all the time and being added to. Now let me move from the causes of asthma, from the pathogenesis of asthma, to the bronchoactive drugs, because these are of major importance in the treatment, the management of patients with asthma. And there are two major classes of drugs, the beta-adrenergic agonists and the inhaled corticosteroids. And they're by far the most important medications. I'll say a few words about the supplementary drugs that are used, including new therapies, but the major classes are the beta-adrenergic agonists and the inhaled corticosteroids. Let's look at the mechanism of the beta-adrenergic agonists. Now, there are two kinds of beta receptors. There are the beta-1 receptors in the heart, which increase the heart rate and the strength of contraction of the myocardium. And there are beta-2 receptors that exist in the bronchi, also blood vessels, and the uterus. And stimulation of these beta-2 receptors results in the relaxation of smooth muscle. Now, I can remember when asthma was treated by drugs that were both beta-1 and beta-2 receptor agonists, but this has changed now, and only selective beta-2 receptor agonists are exclusively used now in asthma. There are quite a number of those available, and they have the advantage of just stimulating the beta-2 receptors, and the beta-1 receptors not affected or very little. These stimulation of the beta-2 agonist receptors increases the activity of adenyl cyclase, which raises the concentration of cyclic AMP in smooth muscle. And so they reverse the changes that occur as a result of the factors released by cells which reduce adenyl cyclase and reduce the concentration of cyclic AMP. That's one of their actions, but the other one is that they reduce airway inflammation. And it's these two factors that are important in the management, the treatment of asthma. And we saw this here in the previous slide, you recall. We made the point that the mediators, and there are a whole variety of these now, this is a rather old list, but a much larger variety now of mediators with two quite separate actions. One is to reduce the inflammatory changes, including the permeability of the capillaries, and the other is to reduce the contraction of the bronchial smooth muscle. Now, the beta-adrenergic agonists have different durations of action, and this is important in the management of asthma. There are long-acting forms, and these include formoterol, salmeterol, and they are particularly useful in the prolonged management of patients with asthma. They are usually used in conjunction with inhaled corticosteroids. But there are shorter acting forms such as metoprolol and albuterol, and they are now largely reserved for rescue use. Whatever beta-adrenergic agonist is being used, it should be delivered by a metered dose inhaler, and patients should be taught to use these inhalers appropriately by demonstrating the way to do that. So now, in addition to the beta-adrenergic agonists, we have the inhaled corticosteroids, of which there are now a large number. And these have two separate actions. On the one hand, they inhibit the inflammatory and immune response, and on the other hand, they enhance the beta-2 receptor expression or function. And they are extremely valuable. Most asthmatics benefit from these medications, and in fact some physicians feel that all asthmatics should be given inhaled corticosteroids. However, there are people who are less aggressive, and a common guideline is only to use inhaled corticosteroids in patients who need beta agonists more than twice a week. So that's one of the guidelines that's frequently used, although, as I say, some physicians would like to use corticosteroids in all patients with asthma. Inhaled corticosteroids have minimal systemic absorption, so fortunately we don't see the more extensive effects of corticosteroids. There are supplementary bronchoactive drugs. One class, and I'm not going to say a great deal about them, one class are the methylxanthines, including theophylline and aminophylline. The mode of action of these is not absolutely clear, but they've been used for many years as adjuncts in the treatment of asthma. Sometimes anticholinergics are suggested because there's some evidence that the parasympathetic nervous system plays a role in the bronchoconstriction of asthma. But generally speaking, those are not very popular, not very useful. It's interesting that anticholinergics are sometimes used in patients with chronic bronchitis who have a degree of bronchoconstriction that can be relieved. There are also drugs, cromolyn and netocromil. These have been used in the past, they're not much used at the present time. And interestingly, there are a number of newer therapies that are coming online. One of the leukotriene receptor antagonists, and another, omalizumab, which is a monoclonal antibody to IgE. It's an expensive drug, but it's sometimes used in patients who are refractory to beta agonists and also to inhaled corticosteroids. Let's turn to pulmonary function in asthma. And of course, the main problem with asthma is the change in ventilatory capacity and mechanics. There are also changes in gas exchange that I'll talk about briefly, but it's the mechanical function, the airway obstruction, which is responsible for most of the distress and the limited activity in asthma. And of course, that can be demonstrated using a forced expiration. And in fact, the forced expiration, the measurement of the FEV and the FVC, are critically important in asthma, particularly in the assessment of the value of bronchodilator drugs. In obstructive disease, as we've seen many times, the FEV is reduced, and that of course is because of the airway obstruction. The patient cannot exhale the air as rapidly as a normal subject can do. But the FVC, the forced vital capacity, is also reduced, and that's because the airways that are the diseased, of course, they have increased constriction because of the increased activity of bronchial smooth muscle. They are edematous, and because of their disease, they tend to close early towards the end of expiration, and that's responsible for the reduced forced vital capacity. Sometimes the effects of bronchodilators are very dramatic, and this is a particularly dramatic example, but you can see that the forced expiratory volume, although it was not actually calculated, the volume exhaled in the first second is enormously increased, and also the forced vital capacity is increased because these diseased airways did not close so early in the expiration. So the measurement of the effects of bronchodilators on the airways using the FEV, FVC, very important in asthma, and the disease is followed all the time by doing measurements of forced expirations. Of course, very easy to do and very informative. The expiratory flow volume curves are also affected in asthma as they are in other types of obstructive disease. Here's the normal pattern here. And in obstructive disease, first of all, typically you start at a high lung volume, and I should say here that the flow volume curves are plotted on in a way that shows total lung volume, but this is not normally available. But it's instructive because you can see that the patient starts at a high lung volume and finishes at a high lung volume, and of course the flow rates are very much lower, particularly during most of the expiration. One of the differences between asthma and COPD is that in COPD you often get a shape like this, where the flow rate decreases in the middle of expiration here, but in asthma you don't get this change in shape of the curve. Now, lung volumes are greatly increased in asthma. Both the FRC, the functional residual capacity, and the total lung capacity are increased during an attack. And it's important that lung volumes do increase. One way of looking at this is that when lung volumes increase, you increase the radial traction on the airways, and you tend to reduce their resistance. Of course, the resistance is increased by the disease process, but one way of looking at this is that if lung volume didn't increase, the increase in airway resistance would be so great that probably it would not be compatible with life. So lung volumes increase in asthma. Also, interestingly, lung compliance increases, but the reason for that is not known. There's nothing wrong basically with the lung parenchyma in asthma. If you look at the histology of the alveolar tissue, there's nothing particular to be seen. So it's not at all clear why the lung compliance is increased. It's been suggested that this may have to do with changes in surface tension, although I don't know that that's the complete explanation there is understood. As we've said, the residual volume is raised because the diseased airways close prematurely in expiration, and that can be explained by both the inflammation and the hypertrophy of the bronchial smooth muscle. Another measurement that's interesting is that the helium dilution measurement of lung volume is usually much less than that measured with the body box, and this is presumably partly because many of the small airways are completely obstructed by mucus, as we saw in one of the earlier images, but it's also probably caused by the fact that there is so much uneven ventilation that the patient does not distribute the helium uniformly throughout the lung in the time available for the measurement, and so we don't see the whole of the lung as a result. Here are some pressure volume curves showing that in asthma, as I mentioned, the compliance is increased. The volume for a given transpulmonary pressure, and here we're looking at volume against transpulmonary pressure, the volume for a given transpulmonary pressure is greater than normal, shown by the red line here, and the slope of the line is somewhat increased. Not as much as in emphysema, but nevertheless there is apparently an increased compliance in asthma. As I said, the causes for that are not clearly understood. And you'll notice that in interstitial fibrosis there's a tremendous reduction in compliance. Flow rates, of course, are reduced in asthma, and one way of measuring those is a forced expiratory flow, which clearly indicates an increase in airway resistance. And the airway resistance can be measured in a body box and shown to be increased. As far as we know, airways of all sizes are constricted. Certainly very small airways are constricted, and if you look at the larger airways, the medium-sized airways, during bronchoscopy, you can see that resistance also occurs there. Now let's look at gas exchange in asthma, and it's certainly abnormal, as you would expect from the airway problems and therefore the uneven distribution of ventilation perfusion inequality. But the changes in gas exchange are not nearly so important as the mechanical changes, the changes in airway resistance, which are responsible for the distress and the reduction in exercise tolerance, for example, of these patients. However, there is clearly a marked inequality of ventilation, which can be measured with the single breath nitrogen test, which we referred to earlier. You recall that in that test, the subject takes a vital capacity breath of oxygen and then exhales slowly, and we record the exhaled nitrogen concentration against lung volume. And in normal subjects, the alveolar plateau, as it's called, is almost flat, always slopes a bit, but the slope is quite small. But in a patient with asthma, the slope will be substantially increased. And you can measure the degree of uneven ventilation by looking at by measuring the slope. So there's certainly a lot of uneven ventilation in asthma, and that can also be shown by topographically by using radioactive materials, radioactive gases, inhaled radioactive aerosols. You can see areas of the lung that are poorly ventilated, as you would expect. There's also ventilation perfusion inequality in asthma. The arterial PO2 is always reduced, although this is generally not very severe. And it's interesting that the arterial PCO2 in asthma is usually normal. In fact, it might be slightly low under some conditions. If there is an increase in the PCO2, the arterial PCO2, and this sometimes occurs in status asthmaticus, this is an ominous sign and indicates the need for very vigorous therapy. You may say, well, why is the arterial PCO2 normal? We know that ventilation perfusion inequality interferes with the transfer of CO2, but as we've said in connection with COPD, many patients with COPD have a normal arterial PCO2, and that's because the body is extremely, quote, reluctant to see the CO2 rise, because that affects the pH falls, that affects the function of enzymes, affects configuration of proteins, affects the central nervous system. So the body tries very hard to keep the CO2 normal, and that can be done in spite of the ventilation perfusion inequality by raising the ventilation to the alveoli. And that's what's normally done in most patients with asthma. They have an increased ventilation to the alveoli in spite of the fact that they have an increased airway resistance, and this keeps the PCO2 usually normal. Now, you can look at the distribution of ventilation perfusion inequality in asthma, and I'm going to show you a couple of examples here. Actually, these are measurements made in our laboratory a number of years ago, and this particular patient was a young patient with asthma. It wasn't all that severe. As you can see, his arterial PO2 was 81, probably should have been in the mid-90s somewhere. So it was reduced, but not dramatically reduced. And this patient, at the time of the measurement, did not feel as though he was particularly diseased at all. His asthma is not serious, although I should say that at this time, probably the management of asthma was not as sophisticated and as aggressive as it is today. And what's interesting is that the distribution of ventilation-perfusion ratios is clearly very abnormal, as you can see. There's one mode where the ventilation and blood flow are situated close to the normal value, ventilation-perfusion value of 1, but you can see a substantial amount of blood flow going to units with low ventilation-perfusion ratios. And presumably those are lung units behind highly obstructed airways, or perhaps completely obstructed airways obstructed by mucus. It's very interesting that in this patient there was no shunt, so that in spite of this large amount of blood flow to poorly ventilated units, there was no shunt. And I think this suggests that the shunt may have been due to collateral ventilation. And just to remind you, there are several mechanisms of uneven ventilation. There's the normal mechanism that we usually think of, where an airway is partly obstructed by mucus or whatever, and therefore ventilation is uneven, and that's called parallel inequality. There's a mechanism called series inequality, where the diffusion of the gas along the airway is compromised, and a possible example of that is centri-acinar emphysema, where the center of the acinus is greatly enlarged, and you may well have some series inequality of ventilation as a result. And finally, there's the mechanism known as collateral ventilation, where gas reaches the alveoli, but not through the usual channels, but through connections between small airways, or even conceivably connections between alveoli under some conditions. But there are collateral channels, and that may be the reason why there was no shunt in that patient with asthma. Now, that patient was given a bronchodilator, and a very interesting change in the distribution of ventilation-perfusion ratios occurred. Again, you can see the normal mode of distribution here, but look, there was a big increase in the amount of blood flow going to lung units with low ventilation-perfusion ratios. Again, no shunt, as you can see. Consistent with this increase in blood flow to poorly ventilated areas, the PO2 fell from its former value of 81 to 70. And what's responsible for this increase in blood flow to poorly ventilated areas is not absolutely clear, but possibly the blood flow is affected by the mediators that are constricting the airways, and they also constrict the blood vessels. When the asthma is treated with a bronchodilator, the function is not only to release the bronchoconstriction, but to release the vasoconstriction to some extent, and that's the reason why the blood flow increases to these poorly ventilated areas. Now, this fall in arterial PO2, a relatively small fall in arterial PO2 when a patient is given a bronchodilator, is seen often. Does that mean that we should limit the use of bronchodilators in any way? Not at all. These changes in gas exchange are interesting, but relatively unimportant, and it's far more important that we treat the bronchoconstriction, which is responsible for the distress of the patient and responsible for most of the physiological changes. Now I'm going to change gear and finish with a brief discussion of localized airway obstruction. We dealt with COPD in the first lecture on airway obstructive lung disease, and here we've dealt with asthma, not such an extensive topic to discuss, and it gives us an opportunity to talk about localized airway obstruction. And we can divide that into tracheal obstruction and bronchial obstruction. Now, tracheal obstruction has many causes. One of them is an inhaled foreign body. In fact, an important cause is if somebody during a meal inhales a piece of meat, for example, gets stuck, then it's important that that be removed. And one way of doing that, I'm sure you know, is using the Heimlich procedure. Stand behind the patient, put your arms around the lower part of the chest, actually below the xiphoid and the upper part of the abdomen, and pull hard, and with a bit of luck you can remove the foreign body. So that's one example of tracheal obstruction, a potentially lethal condition. Another is compression of the trachea from outside. Enlarged lymph glands will often do this, or enlargement of the thyroid gland can do it under some conditions. Or of course there may be a neoplasm either in or outside the trachea which obstructs it. There can also be stenosis of the trachea after tracheostomy, or sometimes after the use of an endotracheal tube. We don't see this so much now, but in the good old days, endotracheal tubes used to have a cuff which was very stiff and would damage the airway wall, and after the tracheostomy tube had been removed, you could get some stenosis of the trachea. Now, if tracheal obstruction is very marked, you can get a stridor, a loud wheeze, an inspiratory and expiratory stridor, because the thing about tracheal obstruction is that not only do you get obstruction during expiration, which is what happens in COPD particularly, but there's also inspiratory obstruction as well. And if the obstruction is severe enough, you can develop a hypoxemia and CO2 retention. Occasionally a patient will come in with some tracheal obstruction which is not diagnosed, or it's misdiagnosed, and he's given bronchodilators as a test of airway obstruction, and there's no response. And that should alert somebody to the fact that tracheal obstruction should be looked at. And one way of testing for tracheal obstruction is to do flow volume curves, which are shown here. On the left we can see the normal both expiratory and inspiratory flow volume curve, and we can see the curve for COPD with its scooping out here, which is characteristic of COPD, and the inspiratory curve is also affected, though not as much as the expiratory curve. But when you do this with tracheal obstruction, typically you get a flattening of both the expiratory and the inspiratory flow volume curves. Particularly the inspiratory one is very interesting, because the only situation, I believe, where you can get that is tracheal obstruction. So that's an important test. Now let's turn to bronchial obstruction. And a bronchus, a major bronchus, large bronchus, medium-sized bronchus, can be obstructed in various ways. In young children, toddlers, an inhaled foreign body such as a peanut is a common cause. And incidentally, the peanut will very likely go into the right main bronchus as opposed to the left, because the left makes a sharper angle with the trachea. Another important cause of bronchial obstruction is aspiration following surgery. When the patient is unable to cough, the cough reflex is dulled, or the patient has pain, not able to cough, and aspiration can cause obstruction. Retained secretions in severe bronchitis can do this. Of course, you can have a neoplasm in a bronchus, or the bronchus can be compressed from outside by enlarged lymph glands, or indeed by a neoplasm outside. And occasionally an endotracheal tube is misplaced. It's pushed down beyond the carina and ends up in the right or left main bronchus, usually the right main bronchus perhaps. Now, an important feature of bronchial obstruction is that it can cause absorption atelectasis. And I want to finish by just telling you about the mechanism of that. The mechanism depends to some extent on the composition of the inspired gas. And if you're breathing an oxygen mixture, of course we don't often breathe pure oxygen, but if you're breathing an increased oxygen mixture, that's quite common post-operatively, because very often post-operatively patients are being treated They're hypoxemic and they're being given an enriched oxygen mixture to breathe. And you can see that in this case with pure oxygen, the sum of the partial pressures in the alveolus is enormously greater than the sum of the partial pressures in the mixed venous blood coming into the lung. And that has to do basically with the shape of the oxygen dissociation curve, that the PO2 can be extremely high, but the oxygen concentration is not enormously increased. When the oxygen is removed from the blood, as the blood passes through the peripheral capillaries, the PO2, the oxygen is removed, the oxygen concentration is decreased, and because of the shape of the dissociation curve, the PO2 falls to a very low value, in this case about 55. So there's an enormous difference between the alveolar PO2 and the PO2 in the mixed venous blood. Because the sum of the partial pressures in the alveolar gas exceeds that in the blood, gas will inevitably move out of the alveoli and you will eventually get atelectasis. And this can be quite fast if the oxygen concentration is high. Now this also occurs during air breathing, but much slower. During air breathing, as in this particular example here, the sum of the partial pressures in the alveolar gas is about 760 normal, but the sum in the mixed venous blood is substantially less. And it's less because, again, of the slope of the dissociation curve. You see there's a big difference between the PO2 in the alveolar gas, 100 here, as opposed to the mixed venous blood, only 40 here. As a result, inevitably the gases move out of the alveolar space into the blood. Now this is a much slower event, and actually it can be shown, it's rather a complicated process actually, but it can be shown that the rate at which the gas moves out has a lot to do with the nitrogen concentration. So in this particular instance where we were talking about pure oxygen, there's no nitrogen in the alveoli. The loss rate is very, very fast. But even small amounts of nitrogen can slow the rate down, and the rate is very much slower in the case of air breathing. Sometimes people talk about nitrogen as being a splint, as it were, which slows the rate of removal of the gas. Now this is an important factor in bronchial obstruction, of course. What you can get is atelectasis of a region of the lung because an airway is obstructed. And that's one reason why we should try and remove secretions if we can. Sometimes this is done through the endobronchial tube, trying to remove secretions. But this phenomenon is also very important generally because it is the reason why, for example, a spontaneous pneumothorax is gradually removed by the blood. In a spontaneous pneumothorax, the same thing happens. The sum of the partial pressures in the pneumothorax gas exceed that in the mixed venous blood, and the pneumothorax is absorbed. The same is true if, for example, inadvertently during intravenous attempts at intravenous therapy, somebody introduces air under the skin, that air is removed by the same technique. Okay, so that's all I'm going to say about obstructive diseases of the lung. The most important topic perhaps was COPD. And again, if I'm not boring you, let me just say that it's so important that we try and get rid of smoking because that is the main factor responsible for COPD. We then went on to look at asthma, again an extremely important disease, quite different from COPD of course, but an extremely important disease, and the amount of asthma apparently is increasing. It's becoming a serious problem. It's sometimes not easy to treat, not easy to control, and the reasons for the increase is not clear. And then we finished with a brief discussion of airway obstruction, of localized obstruction of the airways, which is an important topic, particularly in the post-operative environment. And so I hope to see you next time.